palliative care are basically to provide quality of life and to not hasten the death.
You're not able to see the slides. I think we have to use the glare. We can switch off the lights maybe.
And when they come and talk to the family, and with the amount of nutrition we are providing, it ends up in a lot of confusion and chaos. So there's no simple answers for this, because at the same time we want to make sure that the parents are satisfied. As a parent, you want to make sure that you're providing at least some amount of nutrition to a child, because as a parent, this is a very important parenting thing that you will be doing. So as I said, there's no simple answers to this, and we keep asking these questions. The most important, I think, is to have a dialogue with the family, so that they understand our aims and their aims, and if we can meet somewhere in the middle, that's ideal. So when we talk about nutrition, we're basically talking often about hydration and artificial nutrition, usually when we're talking about it in the context of a hospital. But here you will have the child in different settings. There are children who may be at home, there are children who may be in hospices, and there will be some children who will be in the hospital as well. So you need to look at the place where the patient is in order to decide what is the appropriate form of nutrition that you will be giving. So hydration, of course, is very, very important. And towards the end, a lot of these modalities will change. So you may have a child who is now no longer going for curative therapy, and initially you may be doing enteral, that is oral nutrition, and towards the end, as the child's condition varies, you may be altering the type of nutrition that you'll be giving, and terminally you may be only giving some hydration and no nutrition at all. So the other debate that often people have is, can you withhold nutrition? So nutrition is an intervention, just like any other intervention. Unfortunately, as I said earlier, it's probably not the clearest of interventions. And when you are withholding other interventions, you can actually ethically withhold nutrition. And I think this is something important for at least the healthcare providers to accept. It's often very difficult. So as we said, the WHO looks at all these life-affirming interventions as palliation, and nutritional palliation is also there to be life-affirming, and there's nothing more life-affirming than food. So sitting with the family, partaking of meals is important. In the palliative care, it is often, even if the child can't eat, he should be encouraged to sit with the family, and the family can, if the child is able to eat, they can share the food, and if not, at least participate in the social context of nutrition. So we've talked about the clinical and the ethical aspects, and we've already understood that there can be differing opinions in the healthcare workers themselves, as well as, it's a bit too close to me, okay, as well as within what the families desire. There's not too much data, as I said, so that is a difficult area. And I think what's even more difficult is because in India we don't have any cultural guidelines. Now in India, food is of course paramountly important. Passing stool daily is of course again a very important fixation. So most of my patients, if they're not able to pass stool every day, it becomes a huge topic of discussion. So these are a lot of things that we don't have enough data on, and that is where, since we lack the data, it's important to make sure that you have a dialogue, because different families may have different goals. So it's important to evaluate the disease status, as I said, because this is going to be a changing target. It's not what you decide once for the family and then that is going to continue for the next 3 months. So you need to continually reassess the child and find out if there are any new problems which can cause difficulties with the type of feeding modality that you've chosen. And you need to find out what the parents think about this. So there may be some families where they are very concerned about weight loss, where there may be other complications like mucositis and diarrhea or constipation which have to be looked at. So definitely if you're having diarrhea or mucositis or constipation, these are things that are, even though it's not part of nutrition, but it's something that needs to be taken care of. The child is obviously going to have anorexia because of his malignancy. There may be altered taste due to treatment. So all of these things have to be discussed, because there is no way that you are going to be able to provide the total calorific requirement for a child that is required for a normal child in this patient. So there's a lot of emotional context to food, and when you are discussing this with the family, it's important for you to understand, because when you're talking about providing food to a child, you're talking about hope and comfort and joy, and from the parent side, when they're not able to provide this, there's going to be a lot of emotional baggage that they're going to bring along, and you have to be able to address that and ensure that they don't feel guilty about not providing all the food that the child needs, and making sure that you're taking care of pain, especially if there's mucositis, and talk about all of these things, because if you don't, you're not going to have a very fruitful discussion. So food, we've already talked about. It represents comfort and feeling of normalcy, and that's why even if the child is not eating, it's not a good idea to relegate him to another room in the house. Have him at the table even if he can't eat. So in the framework of nutritional palliative care, we need repeated and ongoing assessment. So as I said, this is not a one-time assessment. You need to look at the nutritional status and the needs of the child. Very important to look at the GI and neurological functioning, because scales that are there, these are not often used in the context of pediatrics, and in different studies of patients, we've found that yes, they do have nutritional problems. Often they get satisfied with just a few mouthfuls of food. Most of them will have anorexia and weight loss. So these are problems that are definitely there. So how to give nutrition? So if we've decided that we're going to now provide some palliative nutrition to the child towards end of life, oral feeding is obviously the most important. So always try to do oral feeding. You can, because the child is going to be eating less, often you can add some oral supplements to the feeding, but again, preferring the mouth as the normal route. Enteral nutrition can be given by other routes. So if the child is not able to swallow or has other problems, you can put in an NG tube or other types. So oral feeding is the most important. It's the most normal, and you can add supplements which are often very easily available and cost effective. It's always a good idea to make sure that the parents understand that they don't need to make the child eat everything. It's not like the usual battle that happens at home with maybe a school-going kid, where the mothers are running around trying to feed the child. So it should be a relaxed environment. Try to cause diarrhea. Those are not to be used. There are some supplements which are very expensive. Again, not really necessary. You can look at home food preferably, and supplements are added onto that only if really needed. As the child gets sicker, you're going to find further progression of loss of appetite, and whatever's going on is going to take, it's going to be more and more difficult as time goes on. Towards the end, often families will say that the child is just taking small amounts of kheer, which is rice pudding or other things, or may just take nourishing drinks. So the nutritional value of these can be enhanced by further adding extra sugar or adding extra butter and things like that. So as time goes by, often the meals will be getting smaller and smaller. But again, it's important to reassure both the family and the patient that it's okay, because towards the end, the child's energy expenditure is also going to be reducing, because the child is going to be less active. So this is perfectly acceptable, but as I said, it's important for you to listen to the mother and let them vent and let them talk about the issues, because often towards the end, levels of guilt are mounting and the child is eating less, and it can become quite stressful. So keep reassessing. Even if you had started off as oral, you may not be able to continue oral, and often it's difficult for us to judge how long the child is going to survive, and so the idea is to keep looking. You may have to put in an NG tube or a nasojejunal tube. There are these percutaneous endoscopic devices that can be used. So this is a little child who's got an NG tube, and so this can be used long term. And the indications for this are really if you can't swallow, or if there's upper GI obstructions. So the nasojejunal tubes are also there. Here, these have to be placed deeper down And again, these are rarely indicated, but you may have some patients because of obstruction, they may require these. And this is a child who has a percutaneously, so this is basically a tube that goes directly into the stomach. So this is used usually if the child has a longer life expectancy, and the child can be fed directly. So there are certain advantages and disadvantages because the child can do his daily activity. But it's important to realize that all of these, I'm going to just skip over some of the slides, and you're welcome to take them later on. It's important to understand that there are problems with these kind of feedings. They can sometimes lead to high glucose levels. They can have electrolyte problems. The tubes can get blocked and cause difficulties. So whenever you're using any of these devices, you need to check the child frequently. It's not that you put in an NG tube and you send the person home to their village, or you put in a PEG tube and you tell them to go back to their local place. The more devices you use, the more assessments you're going to have to give. So there are complications like reflux, GI intolerance, infections, and other things. So especially when we're using these kind of feeds, you have to be careful about infections. So you need to make sure that the product that you make is made with sterile water, using aseptic technique, and even the hanging time is very important for the NG tubes, particularly in our country because it's very hot. So we try to make sure that. Okay. So just the last thing that you have to remember is if you're using any tube, it's important to make sure that you flush after you finish the feed to prevent blockage. So all of these things have to be taken care of, and if we do all of that, we can definitely end up with some good results. Parenteral nutrition we rarely use, and it's very expensive in the Indian setting and requires a lot of laboratory monitoring. So it's something that I would definitely not advise in our Indian setting. Okay, so I think the slides are not moving, so that's pretty much the end. Okay, thank you.